right, so right now we're going to be talking about the esophogram and then moving into the upper GI. We did have the doctor just leave. He was doing all the floral that we started this exam with. You'll notice that the Bucky is moved out of the way and that I'm wearing lead. So now that he's finished with the floral part, we're going to move our Bucky up, and I'm going to take off the lead because we won't be needing it anymore. At this time, we're going to start with our overheads with the esophagus. You may want to remember that you want your patient down a little bit on the bed so that you'll have plenty of room. There's plenty of room here, but just in case, so you have a little bit of room to play with. And at 40 inches.
RPO or LAO, I think is the.
Okay.
I don't remember exactly.
So we're going to just have her turn, just bend your left knee a little. Just turn slightly. Bring your right arm down to your side. And you're going to turn your head because we're going to have you drink a little bit of the barium as I'm going to be doing this x-ray. So we are going to collimate to the 11 by 14.
This is 10 by 17.
10 by 17. Wow.
You can bring it down a little because it's I struggle with it. Are you pushing the left side? Here.
And we're going to make sure that our marker is face down because our patient is prone. So we're going to put that in the prone position. Let our patient know that we're going to be taking a picture as they're drinking to make sure that there is barium throughout the whole esophagus. So just to make sure that they keep drinking. And we're going to step out and you're going to drink. And exposure. You are going, I should have mentioned that you are going to be using your lead shield on this. And then we're going to be doing a right lateral. So your patient's going to turn right. And your hands are going to be up out of the way. You're going to center a little bit lower than about a hand's width down from the manubrium, right at the MCP. Again, we're going to have the collimation at a 10 by 17. The esophagus is right in front of your T-spine, so if you got right centered at your T-spine, you're going to hit that esophagus as she's drinking. And once again, here's your cut. Just keep your arms up as much as possible and just drink. Exposure. That is pretty much the esophagus. Now the upper GI, is there anything I missed on there?
No.
Okay. On the upper GI, the our department's protocol will be prone, as Julie has demonstrated, and our location, it's all upright. So we have the footstool. The doctor starts having the patient drink in an upright position. He'll get to a certain point and then he'll actually lay the table down. And then we take some overheads after that, depending on the department protocol. For some reason, our doctor does everything, so we're real lucky in that in the upper GI. He does, we don't have to do any additional pictures on the upper GI. All right, continuing on to the upper GI, your patient's going to be in a prone position. We're checking, you want to make sure that during your fluoroscopy part of the exam, you're kind of paying attention to where your anatomy is. And depending on your patient's habitus, you may have to center a little bit higher. And also depending on any kind of previous surgeries that they've had or anything else like that. Just make sure that you're checking your fluoro pictures as the doctor is doing it as somewhat of your scout, so that you can educate yourself on the patient's habitus. The PA is going to be at the level of L1, L2. So it's kind of a little bit, kind of like a KUB, so just about an inch below your iliac crest, and then up from there. You don't want to miss anything at the very beginning, because if it goes real quickly, if the barium goes through real quickly, you're going to have your patient drink some more. But just get yourself situated with the pictures of the fluoro, and then that way you'll have an idea when you're doing your overheads. We're going to do a PA, and then we're going to do an RAO. RAO? Mm-hmm. Okay. So you're going to bring your right arm down, your left knee. There you go. Again, that's going to be right at L1, L2. And we're going to do your exposure. Then we're going to move into a right lateral. And this is the right lateral will show the duodenal loop. And that's why it's a right lateral. At the mid-coronal plane, make sure that you're collimating a little bit in, because now you have lateral slide. And this is going to be a right lateral, so make sure that you put your right marker on there. And expose. Okay, now that we've done the upper GI part of this, I wanted to go into a small bowel, because a lot of the times that they are ordered together, not every time. Sometimes we'll just do an esophogram by itself. Sometimes it's just an upper GI by itself. Sometimes it's just a small bowel by itself. But you'll find sometimes an upper GI and a small bowel are all ordered at the same time. And what you want to make sure of when you do a small bowel, whether it's with an upper GI or not, you take a scout before. You want to make sure that you get the anatomy without any kind of contrast in it beforehand. So this would be a small bowel. starting with if we're just doing the small bowel by itself, we start off with a scout. You're going to, because it's prone, you're going to make sure that your marker is facing downward, just like your patient, and then it would be your left marker here.
And I don't know if the book talks about this. The reason we do small bowel follow through prone imaging is because with the patient laying on their stomach, their small bowel spreads out, and you can see the little folds a little bit better, because the small bowel is kind of an anterior. It's not retroperitoneal, so by having the weight of the body on the small bowel, it spreads it out.
Spreads it out.
Yeah, spreads it out. Yeah. It can be AP if the patient can't lay prone, but if they can, it's better.
It's better, and you'll see that they have that little blow up paddle that the radiologist may use even in addition to just the body weight, because they're trying to separate the small bowel to see a little bit better. So you just, this is a KUB, prone KUB, so you're going to find that it's a little bit higher, especially if you want to make sure that you have your stomach in the picture. So you're going to go about 1 to 2 inches above the iliac crest. And again, if you want to get a little bit more, you can, on your image, you could bring your SID a little bit higher to get a little bit more. Okay. This is going to be the scout, then you'll, depending on what your radiologist suggests, they're going to be drinking 1 to 2 mLs of contrast, depending on that, what the exam is for. Okay. I also put down on here something that we do in our department, just because you may step out for a break or something. You want to write this down and then just kind of exit out as you're taking your images. This is all depending on your department protocol. So at our location, it's every 15 minutes for the first hour, and then it's every 30 minutes. We finish at 2 hours, unless the contrast has gone through a little bit faster than that. And so a small bowel follow through is quite easy. It's just basically the same position as far as your x-rays. Sometimes we have the patient lay on the right side to empty the stomach into the small bowel in between pictures. If they can stand up and walk around, that's also helpful to move along the barium through the small bowel.